So quickly just look at some of the anatomy. How is that different than what we've been looking at? What are some of the problems that can result in pain? Again, pointing out, like we talked about earlier, not everything that shows up on pictures is actually painful. And then what do we do non-surgically, as well as what can be done surgically for neck pain problems. So here's an example of the entire spine, and as you know, the neck, or the cervical area, the upper part that our head sits on top of, is considered the part before the rib cage begins, which starts here in the thoracic. Of course, this doesn't show the ribs, but the first thoracic, or T1, is here. And then the upper 7 vertebrae comprise the cervical spine, or the neck, and as you can see, that looks a little different than what we're looking at down here. The vertebrae look kind of the same. They're all scaled down, but the little spindles that stick out of the side here where muscles attach are shaped differently, and they're angled differently. And the upper couple of vertebrae, they don't look a thing like the rest of the vertebrae. In fact, the top one isn't really much of a vertebrae at all. It's just a ring that your spinal cord passes through and your skull sits on top of. So there's a lot of different things that we have to consider, and a lot of different ways the neck can hurt or go wrong and act differently than the rest of the spine, because the shape is totally different. Next one. And so we look at some of the classic imaging tests that help us. You know, the one thing you learn in medicine, and it's true in orthopedics, in every field, 80% of every diagnosis is made by the history. The physical exam helps. Tests like this, yeah, if you have some big cancer that no one had any clue about or something weird, will make the diagnosis. It'll show something no one anticipated. But most of the time, we really figure out as physicians what's wrong or what's likely to be wrong by what you tell us. And as I said, occasionally we have to be patient with our patients, but occasionally be patient with your doc if they're trying to steer you towards things that you don't think are important, or they don't always want to hear about the entire history back to far in the past. Sometimes it's not really relevant and helpful to us, and we often have some really focused bits of things we need to know. Do you get better when you sit or stand, or does it get better when you lean over? And I say, why does he ask me about that? I want to tell him about what happens when I do this or that. We need to know those things, because that really tells us what's going on more than anything else. And we often try not to, but we cut you off, or we don't listen, and we interrupt frequently, and I apologize in advance. We all do it. But it's because we're really trying to get the stuff in a form that we can understand and process to help you figure this out. It's not because we don't want to listen, or we don't feel what you have to say is important. We know it is. In fact, we know that's the most important stuff there is. Okay? So just to reiterate that, we're trying to process it in a form we can manage to help you figure it out. When we get through that in the physical exam, these are the things we look at to help us sort it out. And you're all familiar with these from before: X-rays, MRIs, bone scans I alluded to for the diagnosing compression fracture. That's what these look like. They give you a little injection of radioactive bone tracer, goes through your bloodstream, and 2 to 3 hours later it'll settle out in the bone. They have you lie down under a big camera that's more or less like a Geiger counter that detects the radiation, so it kind of creates this neat picture of the skeleton. And then any place there's any abnormal metabolism, arthritis, infection, fracture, stress reaction, tumor, will show up as an area of increased bone tracer. So you see this person here has some arthritis in their knee and maybe a spot in their neck, which turns out to just be arthritis. It's a where test. It's absolutely not a what test. It doesn't tell us a single thing about what's going on. It helps us hone in on where to look. And then the MRI, and then the remainder, yeah, CAT scan. This is what a CAT scan looks like. And here in the neck you might see if you look real closely, this is a CAT scan, but it's not just a CAT scan. It's a CAT scan where they've injected dye in the neck, or really it's not dye, it's contrast, we call it dye. And you can see the white dye going down through here, and through the middle of it, if you look real closely, you can see the spinal cord running through the middle of that. That's called a myelogram. And that's when they inject dye. The myelogram is when they inject dye and take X-ray pictures, and then this is what's called a post-myelogram CAT scan, and we can see the dye in there on the CAT scan as well, and that'll often help us see little things, which are obviously more common in the neck, being smaller, that can cause some of the problems, sometimes better than even an MRI because of the nature of the size of the test. So what tends to hurt people in their neck? We all know this. Strained muscles, you pull a muscle or a ligament. The so-called whiplash, where your head gets jerked around somehow in a car accident or similar mechanism. All soft tissue injuries that tend to be self-limited and get better on their own. weird and special things like tumors and what have you, these are rare. The most common thing is degenerative disease or maturing type problems like we talked about in the lower back, and that comes in several forms similar to what goes on in the lower back. Disc herniations where there's a rupture, spurs in the bone, and when these pinch the nerve, they can cause what we call radiculopathy or pinched nerve type symptoms. If they pinch predominantly the spinal cord, then it causes what we call myelopathy, and this whole process of this stuff is called spondylosis. So really glad there's no vocabulary test, right? Cervical spondylotic myelopathy, that's the big fancy term for when there's spurs and whatnot pinching the spinal cord and making it dysfunction. So how does that look? The herniated disc in the neck, the true herniated disc, is when the jelly ruptures out just like in the low back, and this is a little artist's conception of that where you can see some of the jelly squirting out through a defect in the lining, and for whatever reason it happens to happen, it tends to come out on either side right where the nerve comes out to your arm and shoulder blade area, and that's where folks tend to hurt the most from these kinds of things. Well, you can get a bone spur that does the same thing, a thickened area in the lining of the joint, and they tend to grow all over the place. But if one grows where the nerve runs, it can cause the same kinds of symptoms. So we look at folks with those symptoms and we don't know what's going on until we get some kind of test that shows us that internal anatomy, and we can resolve it to one of these two major types of things. But as such, they can make it hurt in your neck, they can cause some pain down the arm, so-called pinched nerve, or if they occur more in the center here and pinch the spinal cord, they can cause this cord dysfunction called myelopathy. And that's what we're looking at. So just to kind of expand on radiculopathy, that the radical, or this part of the word is the Latin root for, it's a bad way to put it, the Latin word which is the root for nerve root or root. So anytime there's involvement of the nerve root which dysfunctions, it tends to give you discomfort where that nerve runs, and here where the main nerves that come out of your neck that go to your arms run, each one has a different pattern. So we'll often be really nitpicking and trying to fine-tune, where do you feel this, where do you feel that, what about, where exactly does your pain run? And if sometimes we're thinking you're not giving us a specific or clear enough answer, we're going to really try to fine-tune our understanding and ask you until we kind of get it in our heads, where does this go? Because that is a huge key to sorting out what, on an MRI, for instance, where several things look funny, what is the one that's pertinent to your pain? Where does that go? Neck pain, obviously, but sometimes, too, these things will not only cause pain down the arm, but people come in and complain of headaches. Now, there's a lot of headaches that go all kinds of places, in the front, the back, the sinuses, and what have you. The headaches that you get from problems in the neck tend to be what we call suboccipital headaches, or headaches in the lower part of your skull under the skull base. If you have headache pain there, that can come from your neck. It can come from other things. It's not unusual for it to be from the neck. And then sometimes that will generalize around to the front. It'll go up to the front and get the rest of the muscles fired up. And of course, so it can show up with some of these other areas, but the principal thing that tells us it's from your neck is sort of origin in this area here. Next one. Myelopathy, that's when the cord is pinched by one of these structures. And it really comes in two main kinds. The type you're born with. See, not all of us are born with a big wide canal like this. Sometimes the canal is formed tighter, and that's just the way you're made. And the example of this is, if you think of it as an analogy, you look at the big dog that has big long legs and like a greyhound or something, and it has this long tendency for its bone structure to have longer appendages versus the dachshund. Okay, the dachshund is shorter and stubbier, right? Well, internally the dachshunds tend to have this effect going on. And other dogs or people in general tend to have more of this kind of configuration. So if your spine was made more like a dachshund or whatever, for lack of a better term, you may have predetermined narrowing in there that leads to trouble. And frequently what happens is it doesn't necessarily lead to trouble, but when some of this wear and tear builds up as we age, it leads to trouble quicker and earlier than in the person that has a lot of reserve space there, where a certain amount of pressure may not actually cause problems. So we look at what are you born with, what's the native diameter of your canal, and what kind of wear and tear changes that we just talked about build up and cause pressure. So here's an example of somebody whose spinal cord is pinched. You can see that there's protrusion of these discs here. The cord is the gray tube coming down here from the base of the brain up there, and the white in front and back of it is spinal fluid. So the spinal fluid is kind of eradicated, and with a little imagination you can see that that cord is actually being squeezed by those protruding discs. Next one. So what do we do? Again, the hallmark of treatment for things like this is always non-surgical. Most people will get better or reasonably well without any surgical intervention. And there are many, many ways that can be done. Chiropractic care, physical therapy, sometimes a short period of bracing. Medications like we already talked about. A lot of times injections in the neck will help treat and diagnose where the problem comes from. Sometimes it's hard to get rid of it and we have to rely on pain medication short-term or long-term. And then there's all kinds of other options that can be helpful in the non-surgical treatment realm. But when those things don't work and things are significant or unremitting with non-surgical treatment, then we rely on surgery in some cases, and it's again done in one of two ways like we talked about in the lumbar, either in the front, anterior, or posteriorly. Most of the ones that are done are generally anterior, an anterior cervical discectomy, where we take out the disc, and I'll show you pictures of this, the disc or the bone spurs through the front, or where we have to remove part of the vertebrae or multiple vertebrae to get the pressure off, which is called a corpectomy. Now, if you take part of your neck out, something's not there, right? We can't just leave your head hanging in thin air, of course. So the dreaded F word comes out again, and we have to, after these things, fuse it together, which, as you know now, is done by bone graft, assisted by hardware. If we go in the back, there are some ways that we can do similar things back there, but typically what's done is we just relieve pressure. We take bone off the back and do a laminectomy, just like in the lower back. We may relieve some specific pressure just where the nerve exits without doing the bigger procedure. It's called a foraminotomy. And in some cases, we sort of don't take all the bone away. We just make more room, and I'll show you what that looks like next one. So the anterior cervical discectomy, incision on the front of the neck, these are usually done from left to right. They're fairly cosmetic. This surgery sounds gruesome and uncomfortable, and it probably sounds gruesome because it is, but it's not really hard to do, and it's not really hard to tolerate. This is a very easy surgery for most people to tolerate, especially if you ask somebody who's had one of these versus the ones in the back. Ones in the back go through bigger muscles, and while they seem less threatening because we're not dealing with the windpipe and the throat and the arteries to the brain, these tend to really hurt very little, and people tend to recover from them a lot easier. So we move the throat and the windpipe out of the way. We're looking right at the spine, and then here's the front with the retractors in the place. We take the disc and the spur material out with special instruments, and then we go ahead and put in our bone graft and stabilize it with the plate. And so this is an example of what it would look like with just a one-level surgery, one disc, one bone graft, and then a plate with 2 screws in each vertebrae. Again, recognizing, oh, they did it with a plate. They didn't do it with the plate. They're helping it with a plate. That's the adjunct that helps keep this lined up and makes it more likely to work. The corpectomy I mentioned earlier, that's a little more involved. There may be spurs behind the vertebrae. There may be spurs in so many areas you have to take the vertebrae out to get to them rather than just the simple through the disc procedure. So we can take that out with a variety of tools, either a special drill. There are some other things that look more like something you'd use in your wood shop, but we take great care when we use them, and remove one or more vertebrae, and that's a corpectomy, next one. And you can see here we have to reconstruct that. Of course, you can't use a little piece of bone. You have to use a piece of bone that's big enough to fit the defect. And so we rely on different kinds of bone grafts. Here it looks like we're using a piece maybe from a fibula, the little bone on the outer side of the ankle, from a donor. Or sometimes you donate your own, a piece of your own fibula. We can take that out if need be, and that works, and people do fine with that. And then, of course, a plate, which might be longer because we're bypassing more territory, has to cover the whole area, hold that still while that piece grows together in one piece. And here's an example, it's just of one of my folks, looks very similar to that sort of example x-ray. This is a real person from Hickory. 2 discs, you can see that they're protruding back and limiting the space, pinching the cord. This picture is down the middle. If you look on the pictures off to the sides of the spine, you can see that the nerves are actually being pinched as they exit as well. And this person had kind of a combination of pinched nerve and pinched spinal cord phenomena. And you can also see that the alignment is such that the spine, and this we'll look at this a little more on scoliosis, those vertebrae, those discs are kind of kinking over like that little lady on that osteoporosis slide. They're tilted forward. Through this area of the neck, you really are supposed to have a backwards C-type alignment if everything is lined up. So the cord and nerves are pinched and we have some malalignment. We're able to take those discs out, put little bone grafts in there, and kind of help restore this alignment to where this reverse C-type shape is restored and the other nerves and tissues are in a better environment as well. So that's what it looks like post-op. This is a 2-level discectomy infusion. Bone graft here and bone graft there. Next one. The posterior surgeries, the laminectomy and laminoplasty, are obviously face down for that, and incisions made right in the middle here. There are big bundles of muscles on either side that you have to move out of the way to get to the bone, and that's what tends to make this a difficult surgery for the patient. Those things, when you injure them with surgical trauma, you don't really injure them, but you know, the trauma of moving them, they don't like it, they spasm and they tighten up and they hurt like the dickens. And so this is a lot more uncomfortable surgery. Sometimes it's really the only way or the most appropriate way to go. And so a laminectomy involves taking out the lamina, the posterior arch of bone like we looked at in the low back. Most times in the neck when you're going in to do that, it's a multi-segment problem, so you're going to take out 3 or 4 depending on what's going on. It's not often something you can resolve with one. The foraminotomy is, next one, where we do kind of what looks like a limited version of that. Here, the foramen, remember from the anatomy, is that little opening that the nerve comes through. It looks different in the neck. If there's just a predominance of spurs pinching one nerve right there, we can do a limited removal of bone there and sometimes improve things that way. Next one. The laminoplasty is when we want to make more space, but this tends to, is sometimes necessary, it tends to make the spine unstable. All the attachment points for the muscles are now gone, or a good bunch of them are. And some folks get into a problem where their spine, instead of staying in that reverse C, it starts to progressively kink over time, and we're all familiar with that possibility. So whenever we can make more room and not do this, that's a good thing. And so more and more what a lot of us are doing is a relatively newer technique called laminoplasty. It's been around a long time, but relatively newer than this. And we just open the lamina on one side, we make a hinge to make more room. That sounds pretty complicated. Next picture. It's really not that hard. You take one of those little burrs, those drills I was showing you earlier, and you make a little partial cut down one side, and make a partial cut down the other side, not the whole way through, and then use another little tool to just complete this cut, and you leave that part sort of partially through, and you can kind of crack it like a twig in a way where you can just hinge it open through this part, prop those open, leave them in place as attachment points for the muscles, and gain more room for the spinal cord. And this kind of shows you an example of what that looks like. This little area would normally go from there to there, but we've made a little groove here that we've kind of cracked through. We've made a groove over here that we've cut through, and we've levered this open here and put a little spacer device in that defect to hold it propped open. And then again, here's a little, it's hard to see, but there's a tiny little plate that will help make sure that stays the way you left it. And that's, again, like this in the neck, is often something done over several levels because it's usually a multi-level problem where you have to do this. All spines have curves. Somebody made mention earlier about scoliosis. We're all supposed to have curves in the sideways direction. Okay, the reverse C that I was talking about in the neck, okay, we have that. We have a forward C in the mid-back, reverse C down here, and when all these line up, what that does is that keeps your spine aligned, but it keeps your head centered over your tailbone. And as we age, the tendency that we all get, like those little ladies on that one picture, is that this tends to increase due to softening of the bone and wear and tear of the disc. But it's normal to have some curves. It is not normal to have any curvature in the sideways direction, however. And so you can see here in the context of scoliosis, this is what we see in the straight spine, and when there's a sideways curvature like this, that's never generally normal, and that's called scoliosis. Next one. And there are many, many kinds, but in the pediatric population, the type we see the most is the type that occurs in adolescence during the adolescent growth spurt. It has no known cause, which is what this fancy word means, idiopathic, and of course it's scoliosis, adolescent idiopathic scoliosis. probably 85% of cases out there that you see or hear about are this type, and it tends to be progressive and more common in young women. There's the type that occurs earlier that behaves differently, more commonly in boys. There's the type that you can get where the bone actually malforms in the embryo, and you have malformed vertebrae that progressively grow more curved as the child grows. Types that are caused by dysfunction of the nervous system, and included in there is that's the type that post-polio scoliosis would be categorized in this category. But the type we see most commonly in kids is this type, adolescent idiopathic scoliosis. And the way we determine if you have that or how you measure scoliosis is this angle called the Cobb angle, where we draw lines on the vertebrae that are curved, try to capture the top and the bottom, figure out where it starts and stops, which isn't always as nice and clean as this little picture, which leads you to think. But once you do it a few times, it's not that hard. And if the angle is over 10 degrees, that's considered scoliosis. A lot of, especially kids, preteens and growing kids, have a little squiggle. It's less than 10, it's not perfectly straight. Yes, it's not normal, but it's not really scoliosis. It doesn't get bigger, and it doesn't behave the way that we're concerned about. And we kind of, you know, those folks just get reassurance, and they generally don't need anything done. They don't need to worry. When it gets to be 10 degrees or bigger, those can take on a life of their own and progress, and then sometimes we have to pursue more involved treatment. And the decision making on that's actually kind of complicated, because there's a lot of factors that go into it. You know, do you have a 10-degree curve at age 5, or do you have a 10-degree curve at age 15 when, as a young woman, you're done growing and it's not going to get bigger? You know, is it a 10-degree curve or is it a 25-degree curve? That means something different. And the big thing is that these things in the adolescent population tend to progress while you're growing, and the faster you're growing, the faster they progress. So we look, you know, we have to put that in the context of progression. And that's how we sort out what we do. It's not just a number or you know, a gender or an age. There is a nice test called the Scoli score that's out. This is something that's fairly new. It's a saliva-based DNA test that works for a certain subpopulation of adolescents. You can send it into this lab out in Utah, and they've got this fairly well worked out. And that allows us to bypass, in some cases, a lot of unnecessary treatment. Because if you get a low number on this, it's about 90% accurate that you will not progress, no matter what that number is at this or that stage. And if you get a high number, maybe over 250 or more, it goes up to 300, it's about guaranteed that you'll progress. And sometimes we can institute treatment earlier for those kids, or we can get to a more aggressive treatment that you wouldn't normally recommend now because you know they're going to have trouble, and prevent things from getting worse quicker. So that's something that most of the orthopedic people that do spine will know about this, and it's generally covered by insurance, and it's a very helpful tool that's evolving. One day the genetics that are used for this now are going to get to the point where we can give your daughter the test because you have scoliosis and find out if she's going to get it. But at this point, the science has only worked out to the point of if you have a given curve, how likely is it to get worse? So more to come on that type of thing. Next one. What are the basic treatment options? It's all simple. It's really two things. You either keep an eye on the curvature if it's non-surgical, or you brace it. And we watch little curves in people that are unlikely to get bigger, and we brace medium-sized curves that have a potential to get bigger. And it turns out that the bigger the curve is when you show up, the more likely it is to get worse. And the younger you are, the more likely it is to get worse because you have a lot of growth potential. The generally accepted range where we consider bracing is around here, 25 to 40 degrees. There are a lot of good studies that show bracing works. If you come to our big international scoliosis meeting that they have once a year, the Scoliosis Research Society, you'll have people get up to the podium and insist that it's absolutely a waste of time and useless, and there's no science to support it. And you'll have another gentleman that's in his 70s that's done this for 45 years, who's published more papers than anybody, get up and show you convincing evidence that it does. It's a very controversial area. Most of us that do this and treat it traditionally believe in bracing, and most of us will try bracing, but you'll hear all kinds of stories about that. And I think the best science and the most accepted information is that it does play a role. If you brace the right curve the right way and you have somebody who's compliant with using it, in most cases about 85% of the time it's going to help control the curve and stop it from getting bigger to where the person might need surgery. And our goal is obviously to keep the curvature as small as possible, but our real goal is to keep it under 30 degrees by the time you're done growing, because people under 30 generally never progress as adults. If you get to skeletal maturity at about 50 degrees or more, there's almost a universal tendency for those people to get bigger and bigger even though they're done growing. And it's a real difficult thing because it's hard to prove. It gets bigger at about 1 degree per year. You cannot measure 1 degree on an X-ray. These X-rays are plus or minus, every one of them for scoliosis are plus or minus 5 degrees from measurement to measurement. So it takes 5 years to figure that out in a growing person. So now you're 21 and it's 51 degrees and you're not sure if it's getting bigger, and then you come back and you're 26 and you have a child and a job and it might have gotten a few degrees bigger. Come back in 5 more years and you're 31 and it's definitely bigger and you've got 2 kids and a job. And what do you do? So we're desperately trying to keep these people as small as possible so we don't get into this thing with progressive problems later in adulthood when the surgery is much harder and you just can't do anything. It's hard to take the time to do something about it. So surgery for folks that get up to this 50-degree range, they're still growing and we know they're going to get worse. Or they can't or don't work, the brace doesn't work. They won't wear it, they don't wear it, and you know they're going to get bigger. Sometimes we consider surgery. Next slide. And that's done in one of 2 ways. Next one. Either anterior or posterior, or occasionally we do both. So let's look at those. This is done usually for curves in the low back. It allows us to straighten things out without including as many vertebrae. But because you're going through the front by the organs, there's some theoretical complications that don't occur the other way. These things almost never happen, but they can, and when they are, they can be drastic. But they're really, really rare. Going in the back is the traditional way. We tend to do it in the thoracic spine and the upper part where the rib cage is, where most of these curves tend to occur in the first place. And so that's most commonly done. The combined anterior and posterior were either done on the same day or staged, one procedure one day, another one a week later. That's generally done when the curves are real big and rigid, they're hard to correct, and you need to loosen them up in the front so that you can get some correction and increase the rate of fusion success, and then you fuse them in the back as well. Next one. So how does that look in the front? We make an incision in the chest or the belly depending on where the curve is located. You kind of move the organs out of the way. People come in and say, well, they took my organs out and then they did the surgery. I say, like, what did they do with them? Well, they put them on the table while the doctor did the work. And it's kind of an interesting idea. That you say, well, not exactly what happens, but they're easily moved out of the way. In the chest cavity, you can deflate the lung. It gets out of the way real easily. This is not hard to do. And again, it depends on the level of the surgery. But we take out the discs in the area that's affected. That loosens up the curvature because those discs get stiff. We pack some bone chips in, which again, you know, that's the hallmark baseline procedure that causes bone to fuse, putting in bone graft. And then we put in some screws and rods that allow us to straighten the spine and most importantly, hold it still while those chips grow together and the correction gets maintained so that over the months afterwards that fusion occurs. And it takes about 6 months. And then we get a stable, hopefully solid, straighter spine. In the back, very similar to what you've seen so far, just more extensive. Expose that through an incision in the back. We straighten it out with the hardware, put in bone chips, and same thing, wait for the fusion to mature. And if we give it time, it'll stay straighter if that bone grows together. This is a young lady that I did last summer, May. She came in at this point, she was probably about 12, if I remember correctly. Still had a fair bit of growth remaining, had a moderately big curve. It was getting bigger despite bracing, and you knew she was going to keep growing and this was going to get unmanageable. So wound up taking her to surgery and doing a selective fusion where we just fuse the upper curve, and in select cases you can do this. You allow the lower curve to spontaneously straighten itself. You keep the lower back mobile so you don't get into this arthritic problem with worn out discs later. So I don't have good pictures of that, but you can see the upper curve straightened up nicely. She's about a year out. She's doing everything, gym class, feels great, looks great, and feels a lot better about herself. That's what that looks like. This is another young lady I did. Again, this was last May, and you don't see the lower curve as well. It's not quite as big as this, but she was in the same category, fairly young, high progression potential, fused the upper spine selectively, got that nice and straight, and as you can see, The lower part will often follow in the right kind of candidate, and that will allow it to straighten out, stay mobile, and not get into problems with delayed deterioration.